Hello and welcome everyone to this ORCHA webinar on how to reduce urgent care pressures with digital health. It's a pleasure to have you all join us today from wherever you're dialing in from today. I know we've got some people dialing in from the US today, so welcome. It's probably a very early morning to you there. My name is Dr. Tom Micklewright. I'm the medical director at ORCHA and I'm also a practicing GP working in Chester. So this is a subject that's really close to my heart, how to reduce pressure in urgent care. And I'm joined by an esteemed panel of guests today. Helen, could you take us to the next slide? I'm joined by Dr. Simon Lee, our Director of Research at ORCHA, and also joined by Helen Hughes, Chief Executive of the charity Patient Safety Learning, and also Chris Effords, Clinical Lead Physiotherapist and Digital Fellow based down in Dorset. So welcome to all of you and thank you for joining us for this webinar. Next slide, please, Helen. So we're here today to talk a little bit about urgent care, and you all have probably seen in the news and videos, photographs, images of patients waiting in corridors to be treated or ambulances queuing up outside of accident emergency departments. You might have heard patients yourselves expressing despair at the thought of going to A&E and wanting to avoid it altogether. And if you work on the front line, you've probably felt that sense of wanting to do more, but being limited by the resources available to you. There are immense pressures being felt at the moment. And they're being caused by a cocktail of different things. We're just coming to the end of a difficult winter where we've had a spike in the usual respiratory infections like flu and cold viruses, but also COVID-19 is still hanging about. We had the strep A scare affecting children, and all of that is coupled with the fact that we're experiencing a financial tightening in the NHS. There's still an elective care backlog, and we're struggling to discharge patients out of hospital. So it's all been a recipe for a very high pressured situation. All that means that the 4-hour wait target for A&E has been missed every single month since July 2015. And in many places across the country, up to half of patients are missing their 4-hour targets. So no wonder then that the NHS, the government, you might have heard, have announced £250 million in funding for discharge front-runner sites, 6 discharge front-runner sites, to try novel solutions to getting more patients out of hospital beds faster, including through the use of tech. Also telling them that Steve Barclay was quoted as saying he believed up to 20% of urgent care attendances were potentially avoidable if the right care was in place. Next slide, Helen. Now, we're all here because we believe that digital can be a contributor to solving some of these problems. And we definitely think that's the case when we're talking about right care in urgent care. We had a look at all of the SNOMED CT diagnostic codes used for attendances at A&E and urgent care centres from 2021 to 2022. And although we found the majority of them related to diagnoses that were unpredictable and unavoidable, things like head injuries or fractures, a significant portion we found could be clustered around 5 main groups of presentation. They are mental health, presentations due to long-term conditions, preventable acute episodes, so things like MIs, strokes, things where there are significant risk factors that could have been targeted or controlled better from the off, musculoskeletal conditions, and also acute minor infections, such as ear infections, UTIs, and sore throats and the like. Now, we found that across those 5 groups, that accounted for about 35% of all of the diagnostic codes used for people attending an A&E. And we believe that digital can significantly impact each of these 5 main regions. We don't think digital is necessarily the sole solution, and by the time someone turns up on the door, they're not going to replace the need for a patient to see a doctor or a nurse. But when used across a care pathway, we believe that digital here can potentially prevent people coming into accidents and emergency, or when they turn up, can speed up the efficiency with which they're diagnosed or treated, or when they're discharged, reduce the likelihood of them reattending in the future. Next slide. If you've been on our webinars before, you'll be familiar with ORCHA, Organisation for the Review of Care and Health Apps. And what we're all about is making sure the best, safest, and most effective health tech gets into the hands of those that need it. There are over 350,000 digital health tools out there, but we know from our experience that only a very small portion of them pass our quality standards. You can see here that between 85 and 89% of apps covering these 5 main regions fail our standards. So it's a significant challenge working out the wheat from the chaff, which are the best solutions to use. We've also, whenever we're assessing apps, we're looking to make sure, are they data and technically secure? Are they appropriate for patients to use? Have they got good usability data? And also, have they been professionally assured? Is there a robust evidence base? Have they been clinically risk assessed? Now, if you go into the report, the urgent care report that accompanies this webinar, you'll see that we've actually recommended or given examples of some apps that we think could be used for these different conditions, just to kind of illustrate what digital can do in this space. They include things like MyMHealth, which can support COPD patients with self-managing their COPD, potentially preventing them from needing an urgent care appointment. They include Pathway Through Pain, a chronic pain management course that could be given to patients presenting in urgent care with back or joint pain and prevent them reattending. And they include Wiser, an artificial intelligence chatbot designed to support patients with anxiety or depression. So there are a number of tools, high quality tools, that can be deployed in this setting. Next slide. Interestingly, when we've surveyed the population, we found that the majority of people, 62%, do believe digital can play a role in relieving pressure in the NHS. But interestingly, only about half of people that are already using health apps have actually been recommended an app from a healthcare professional. And this presents an opportunity gap. In the report for each of those 5 main condition categories, we've created, for illustrative purposes, a persona, a kind of typical patient that represents that group. And we've identified the likelihood of that person using an app versus the likelihood, based on our own data, of them actually being recommended an app. And that represents the opportunity gap for each of these conditions and gives an idea of the size of the impact digital could have in this space. So there is definitely an appetite, and if we get this right, if we close that gap, the impact can be huge. Next slide. So now I'm going to hand you over to our research boffin, research director at ORCHA, Dr. Simon Lee, to talk us a little bit more about that impact, especially the return on investment. Over to you, Simon.
Thanks, Tom. Thank you very much. So yeah, as Tom suggested, we had a good, decent look at this and how digital health may be able to, take away some of those pressures on the NHS, particularly in urgent care and especially over the winter months. We know that the NHS really does struggle, particularly with A&E, ambulance journeys, etc. So we wanted to really look at this systematically, look at the evidence, and say, okay, what can digital health actually do? So we set out in a rather protracted way, I'm not going to lie, it took quite a while, searching for all the evidence that we possibly could around the effectiveness of digital health and around existing pressures in the NHS. We looked at everything from the number of people who live with a long-term condition in England, about 15 million as per the King's Fund. We looked at the number of people with a long-term condition in the average ICS, about 350,000. And then we modelled, okay, if we could get a digital health technology that is evidence-based, proven to work, and to have an actual tangible impact into the hands of a select number of these patients, what would be the impact? And the way that we did this basically was we went GP practice by GP practice, worked out how many there were in the NHS in total, obviously a significant number. We looked at the number of GP appointments that are taken every year, and we thought, okay, if we can get a very small percentage of the patients on long-term condition backlog lists to be recommended digital health, And this was a small proportion. It was somewhere in the region of 5 to 10%. And we said, okay, and then if only 28% of these open the text message. So we know from previous research looking at things like ophthalmology screening, cancer diagnostics, that about 1 in 4 times when you receive a message from the NHS, you'll actually go on and open it. The other 3 and 4, you'll just say, oh, I'll get to that later, and then completely forget about it, and then you'll get the follow-up. So we said, so what if that 1 in 4 did open it? And then what if only a small proportion of that group actually then went on to actively look for a digital health app? And again, a small proportion of those went on to download it. So we kept getting a smaller and smaller and smaller group ultimately. And what we found with this was that if we're able to recommend a high quality, evidenced is the critical thing here, evidenced digital health technology, we can expect a rough saving of around 60 Great British pounds per user. And the reason that we've got that estimate is that we've seen estimates from NICE looking at the effectiveness of sleep and digital health technologies. I won't name any specifics, we'll all know a few. And we've looked at other evidence to suggest that that benefit is in the region of £60. And we found plenty of other evidence to suggest that smoking cessation apps can deliver up to £110 of benefit. Those mental health far higher, and type 2 diabetes even greater. So we stuck with about £60. We said if every person that actually downloads a health app and actually uses it and sticks with it, that's the important thing, can use this and get a benefit, and that's about £60 per every successful case that the NHS can get back. And we're dealing with big numbers here. 15 million people with a long-term condition. Even if only 1 in 100 of those people actually go through and download a health app, that's 150,000. You start to get the idea that with £60,000 of benefit straight away, you're sitting at 9 million straight away. So it's not the size of the magnitude of the app that makes the difference. It's actually the great scale of the numbers that we're dealing with here. And that's the key here, making sure that we can do this at a wider level rather than expecting too much of smaller groups. So anyway, we went through this and we looked at the potential impact of this. We looked at what would this actually do? How could this help the NHS? And we looked across this for a variety of metrics, and we found that across the entirety of England, if we could get people through long-term care actively downloading health apps throughout the entirety of England as a national policy, and including some elective care in there as well, we'd be looking at some serious impact here. We calculated about 5.9 million new GP attendances, and the way we calculated that quite simply was that a GP attendance roughly costs about £40 today. GP salary, the amount of time, 8 to 10 minutes, it's about £40. So for every £40 we unlock, that's basically a GP appointment. Another way of looking at it is that if we save enough money for 10,000 GP appointments, we pay for a new GP. That's their workload. So, and that's the way that we did this. We know obviously that if we can cut back GP attendance through digital health, because not everybody who attends in primary care often needs to be there. We know this. We know that often you can do things at home. A small proportion of those people who turn up are going to then be referred onto A&E. But importantly as well, a small proportion of those who can't get a GP appointment are then going to go to A&E. And that's the other key thing here, that a lot of people who end up in A&E do so because they can't get these primary care appointments. So we said, okay, if we look at the proportion who we expect to go through because they can't get an appointment, and we calculated it was 11%. So 11% of ED attendances are because you can't get a primary care appointment, and that came from NHS-wide data. So what would it look like if we could perhaps save 10% of those with the cost of an A&E admission of £300? And we kept doing this, going through and through and through, and we got an overall average value of about 550 million, which sounds like a ridiculously high amount, and it does. But that's because we're dealing with such high numbers of patients. When you start looking at the minutiae of this and breaking it down and saying, okay, well, if we did this and if we did that, we'd start pulling it into a more manageable figure. But there's some significant opportunity here if we can have a move in getting people to utilize digital health for long-term condition management, purely because there are so many of us that have a long-term condition with 15 million. So it's that incremental gains over a large number of people that's really going to make the difference here, rather than expecting an absolutely gargantuan saving for a small number of patients. I think that's me, Tom. Thank you.
That's brilliant. Thank you very much, Simon. And a really important message, like you said, about incremental gains and the value of working at scale. And that's the advantage that digital health brings, right? It's the massive scalability of it. Helen, could you go to the next slide, please? So next up, we have Helen Hughes from Patient Safety Learning, taking us through her perspective on urgent care pressures and digital health. Over to you, Helen.
Thank you, Tom. Fascinating presentation from you and Simon. So I'm going to reflect the context with which I'm speaking around patient safety and some reflections of the opportunities, but also the challenges in this area around patient safety. So next slide, please. So who are we? Well, we're an independent charity for patient safety. We've been running about 4 years, and we do the classic campaigning, awareness raising, policy influencing role for more good stuff, less bad stuff. But we also provide guidance, advice, support, and some resources to help improve safety. And in that regard, we work in partnership with others who are promoting good practice. So we're delighted to contribute today, but also we've been working directly with ORCHA on the design of your standards and integrating patient safety as a core part of your review process. Next slide. So it's a huge issue. I mean, you've highlighted the urgent care problems that are immediately facing us in the UK and particularly NHS England. But unsafe care is a global problem, and which is being exaggerated by the post-pandemic world that we live in. So these are World Health Organization figures about the scale of avoidable harm, and well, I've used the avoidable deaths. I think the 11,000 figure that we've been quoting in the UK for the last 20 years, that's definitely doubled in a post-pandemic world, particularly if you look at the modelling and the advice given by the Royal College of Emergency Medicine about the impact. So, so this is a huge problem. Excuse me. Internationally, that's 3 billion avoidable deaths. It's probably more people die from unsafe care than they do from road traffic accidents. It's a huge issue globally. And I think your focus there, Simon, particularly on the value for money opportunities are very well made, given that OECD figures suggest that somewhere in the developed world between 13 and 15% of all healthcare spend relates to unsafe care. And it's not just the cost of clinical negligence, which is astronomical, but it's the additional costs of providing additional support and care for when things have gone wrong and unintended harm has happened. So the kind of the perspective that we have, and next slide please, is, you know, across healthcare, why are we not addressing the scale of avoidable harm? Have we normalized how we operate? What more do we need to do? So in some policy work that we did at the beginning of the charity, we analysed the research, the evidence base, the inquiries from the UK and globally, and highlighted that we don't operate in healthcare as an effective safety management system. This is nothing to do about whether you're independently provided healthcare or the NHS. This is a global phenomena. And I will just highlight a couple of those areas around safety standards and designing safe systems. And I think this talk today really highlights those particular areas, which I'll expand on in a bit more detail. So next slide, please. And in the report that we produced about designing for safety, not addressing harm, it's the theme that safety is a system issue. We have to look at the various components. And I think, Tom, you've highlighted that about some of the drivers for the current problems we have now. I would add to that a kind of workforce and workforce capacity. And the lessons from human factors in other industries is that we have to design our systems to be safe and effective for the staff that work within it, so that they are physically and psychologically safe in their work, but also they're provided with the resources, the tools, the knowledge to be able to apply their expertise and to deliver safe and effective care. And I think the work that ORCHA does is absolutely kind of central to that kind of messaging about designing for safe systems. So those are some of the themes in our blueprint, and we've designed organizational standards to help organizations assess themselves against that and deliver safer care. So I won't dwell on those, but on our website you'll be able to find all these resources. Next slide, please. So I won't focus on this slide particularly because you've covered that in much more detail, sort of, Tom. But I would like to reinforce that we need to put the conditions in place to help patients and staff in delivering safe care and in receiving that, and it's a partnership. So one of our core focuses of foundations for safer care is around patient engagement, and I think where you're looking at digital health and particularly digital apps, it is that interrelationship, the co-production, the shared decision making between clinicians and patients that is so important in enabling patients to use with greater confidence and value those health apps to make the changes to monitor their health, but also to make the changes in health that they need to undertake with support. Next slide, please. So I'd like to just highlight on some kind of awareness and engagement issues around the applicability of digital health and indeed health apps. And as you said, Tom, 89% of apps fail your standards. So it shows what a big challenge that we have in looking at all those 350,000 apps that are out there. So huge variation in how a patient is recommended a health app or could be recommended by a health professional. And we've just put a few of the barriers there. Some of them are similar for professionals, some of them are for patients. A big issue of digital literacy and whether patients and family members are digitally literate in order to use the apps. But let's be clear that we don't apply unconscious biases in this. I think there's a perception and that might be a barrier to using them, that older people will have more difficulty in using digital technology and apps, and the research evidence has shown that that's not necessarily the case. So how we use those apps is and how we prescribe and use those is really important. Knowing what apps to trust is absolutely essential for both patients and for healthcare professionals. We've highlighted there about it's a behavioural change for patients in using apps, but it's a behavioural change for professionals too, and addressing maybe the perception that using an app compromises the relationship between a clinician and the patient, and that might be a seceding of power or authority or influence, and there may be a nervousness of professionals. So there are issues in this kind of the application of this new technology that we need to be aware of. Next slide, please. Yes, so I think there's substantial evidence that the introduction of new technologies, whether that's medicines, medical devices and others, is poorly, the implementation of those and the patient-reported outcomes and the is not always well understood or captured, and the opportunity for patients and professionals to respond with concerns if they're not getting the support they need can fall far short. So this is an area not specifically related to your report, but a broader sense of how do we capture when health apps are working well. Clearly, I would be fully supportive of the standards framework that ORCHA goes through, but it's also how those apps are used in practice and what might be the unintended consequences of people not using those apps as planned, and what support might they need. So another theme I think is also about how do apps address changes in patient acuity. So if you're prescribed an app for a set of conditions, if your health deteriorates or you've got concerns, how do you then re-engage with your clinician? How do you then make sure that the monitoring is appropriate, or the action you're taking is appropriate to your situation now, not just when it was applied? And then we've given the example there of a diabetes app where you may get contraindications that are unexpected. So the theme there, I think, is making sure that the the focus is always on the patient, and that the app provides support to the patient, and it's not about just the app per se, but it's meeting the full needs of the patient. And that's why critically it's so important that the clinical role is so strong in guiding the use of the apps. Next slide, please. So when we talk about safety of health apps, what do we mean? And I think you know, it's kind of how safe in the way recommendations are made, which app to choose. And this is some of the work we've been doing with ORCHA. How is patient data stored and used? Safe in the way that patients interact with a tool, the way the information is used to monitor and monitor and track a patient's progress. And I think particularly that how apps support patient behavioural change. I mean, that's the prize, if you like, with the designing a safe system and designing the interrelationship between the patients, their clinician, how they're supported, particularly in primary care, and to prevent unnecessary attendance and A&E that requires often behavioural change by the patient. How is that maintained and monitored? So this is not intended to be a kind of negative, don't do apps because there are problems here, but in order for the opportunity, the prize that you highlight, Tom, about the opportunity to improve support for patient care, but also to minimise the avoidance of unnecessary A&E admissions, we need to make that we've got this. We need to ensure that we've got the systems in place, and for that, safety, we would argue, patient safety needs to be at the heart of that design, development, and deployment of apps. So next slide. And this is just a couple of plugs really for patient safety learning while I've got you. So one of the things that we do is to promote and share knowledge about patient safety, and we do that through the provision of a free learning platform called The Hub. Since we set it up, we've got now nearly 1.3 million page views, both from the UK and globally. There's a lot of fantastic free content there, highlighting risk, but also good practice in safety, from patient testimonies, staff engagement, peer-reviewed literature. I commend you to use it if you like it. Tell your friends. We have a zero marketing budget, so all our engagement, which is fantastic, it's doubling every year, is through word of mouth. So that's why I plug it. And the last slide is so when you get the presentation packs, you'll have our contact details. But the final point for me is digital health and apps are a huge opportunity to improve the safety and efficiency of healthcare, and commend the report that you've published today as a big contribution towards that, and look forward to supporting ORCHA in the continued excellent work you do on the review and raising the standards of apps to improve healthcare and patient safety. Thank you.
That's lovely. Thank you, Helen. And I've definitely been jotting down some questions I'd love us to explore together around safety, urgent care, and the pressures they're facing and how digital can help. But we'll save that for the discussion. For now, though, I'd like to introduce our third speaker for today, Chris Efford, who's going to be telling us a little bit about how to engage the workforce in digital health. Over to you, Chris.
Yeah, so I'm a physiotherapist by background, working at University Hospitals Dorset, but I've been seconded into a post as a digital fellow for the Dorset ICB, looking at increasing engagement with the app library, particularly within certain professional groups among our workforce. Next slide, please. So I'm going to talk to you a little bit about the project, talk about the measures that we're looking to use to try and maximize our engagement with the ORCHA app library and successes that come with that, and then talk about how we're evaluating that project and monitoring our outcomes. Next slide, please. So the app library has been commissioned by Dorset ICB for a little while, but we know that there's been good engagement in some groups, but not so much with others. So public health, for example, and social prescribers have been, real early uptakers of and use of the app library in terms of recommending apps to patients for self-management purposes. We know that when apps are recommended directly via a clinician, patients are much more likely to go on and download and use those apps in the long run. And so we want to try and broaden the recommendation of apps and the use of the app library amongst the rest of our workforce. So the Dorset ICB decided to fund a 9-month project where they've employed 2 clinical digital fellows, myself and another physio, to represent the allied health professionals group across the county and to look to try and promote the app library and get people involved a little bit more. And I think what I'd say is, although this is about promoting the use of apps and prescribing of apps, it's also about changing some of the culture around digital for our workforce, getting people to think more about digital solutions and become more comfortable with discussing that with their patients and recommending things to their patients. So we're looking to do a series of targeted engagement events and materials, spread across the county to try and, like I said, maximise that kind of engagement. Next slide, please. So in terms of strategies that we're using, there's 6 main domains really. So we spoke to clinical departments and clinicians, and we asked them how they'd prefer to be engaged. Face to face, overwhelmingly, was people's choice, and so that's what we're looking to do. We're going out to look to showcase particular apps that we feel are appropriate within those particular pathways. At the moment, we're focused mainly on a musculoskeletal domain because that's my clinical area of specialty. But I think that relies on, or that strategy works across specialties. We're looking to make a brief introduction to digital safety, get our clinicians thinking about, like what Helen talked about, the safety domains that come with judging the quality of a digital solution. We're looking to discuss apps and how they may map within the pathways that are specific to that clinical service. We're looking to do what we can to reduce the burden on clinicians for prescribing or recommending health apps. And I think Helen talked about plenty of the barriers around prescribing for professionals. But one of the first things that springs to mind is that you talk to people and they automatically think this is something extra that I've got to do on top of the clinical burden that I'm carrying already. And so the more we can streamline that process of getting app recommendations out there, the better. And also learning from successes, gathering what people are doing well, and trying to broaden that across and learning across to other specialties. Next slide, please. So in terms of our face-to-face engagement, we've really looked to try and get a good geographical spread across the county. So in terms of Dorset mapped out there, those purple points on the map are where we're looking to go out and engage face-to-face with our clinicians. So we're trying to make it as easy as possible for people to face-to-face attend these things and not have to travel too far. And we're also looking to align it with existing clinical service training. So often there's some challenges that come with that, in that you have to book clinical departments quite far in advance because of their clinical workloads. But given between 6 and 12 weeks, if you can book that far in advance and align that training within existing in-service training pathways that they've got, we're finding that's quite a good way to catch the most professionals in one place all at one time. Next slide, please. And then in terms of showcase, we're looking to do some hopefully fairly interactive showcase of apps. So this one in particular is one we've been showcasing, Wobot, which is like the WISA app that Tom introduced earlier. It's an AI chatbot which is there to tackle or take a CBT approach to mental health problems. And we're talking about it to clinicians, but we've also got some video demonstrations, trying to bring that alive and help to see how that may apply to patients in their particular setting. Next slide, please. In terms of introducing digital safety, I tend to take quite an overview of this when introducing this to clinicians, and I do talk about the different domains of data privacy, data security, making sure that the apps are clinically effective, and the user experience. But I think as well, making use of the ORCHA Foundation modules that are provided as part of what we've commissioned ORCHA for, because it's signposting people to those and getting people to understand a greater deal about digital safety and how these apps are reviewed by ORCHA. I think again is part of that changing culture piece and getting people more comfortable with digital solutions in general. and also to get them thinking about applying those thoughts to app recommendations that they already make. I've come across plenty of clinicians who are recommending apps outside of ORCHA, apps that they've just come across or their patients have highlighted to them, and nobody's done any sort of governance over the quality or the safety of those apps. And so talking through these things, getting people to think about, oh, actually, that app that I have been recommending, is that safe? Is that appropriate for my patient? Next slide, please. We're looking to talk about pathways. So this pathway is an example from a musculoskeletal physiotherapy department, but we're asking people or clinicians to think about, we're discussing, we've showcased these apps. Who do you see as the target audience for this? How are we going to get that to that patient? And in what way are they going to go on to access that? And we're asking people to think about that throughout their pathway. Next slide, please. This is how I tend to map it to those pathways in front of clinicians, thinking about, where is this app going to fit? Is it going to best fit within those face-to-face contact times? Is it going to be a tool that they use on discharge to support people in self-management after they've left that clinical service? Or is it something that could be brought in while they're waiting for your particular service? Next slide, please. We're also looking to produce poster materials or written materials, poster materials, and things that can go on waiting area displays, so that if they are directly patient-facing apps that are appropriate for general health, general well-being, the patients can access those without having to maybe bother that a clinician is the wrong word, but the burden's taken away from the clinician to focus on patients accessing those directly. And we're looking to use QR code scanning to do that. Next slide, please. And similarly, we're looking at some produced paper handouts, again, to reduce the burden on clinicians in clinic. Seems a bit backwards, doesn't it? You're looking at a digital solution, and yet we're talking about paper. But actually, we've had really good response from our clinicians with this, where they can pick up a sheet, give something to the patient leaves the department with something that they can access and is recommended by their clinician. Next slide, please. And then finally, we're talking to our groups that have gone on to become successful users of the app library to find out the ways that they sort of introduce apps or talk about apps to patients, the way that they use the ORCHA library itself, and the recommendations process, and then looking to translate the learning from that. And similarly, we've also been talking to struggling groups. If you've seen ORCHA much before, we do get metrics from ORCHA on rates of recommendations and hits and downloads, so we can see which areas are performing better than others, and we can learn both from those successful groups and from those struggling groups. A couple of the really key themes that have come out from those discussions has been patient trust in those recommendations, the text process of people receiving an app recommendation by text. Interestingly, a lot of our patient groups have talked about skepticism and scam, being wariness of being scammed, and so making clinicians aware of that, so they can talk to their patients and say, look, it's going to come through as a text message, it's going to look like this, you can trust this, this is not a scam, and you can go on then to download that app and make good use of it. And similarly, clinician awareness, in particular, when there's changes to apps or new solutions become available, making sure that clinicians are able to be aware of those changes, and the app library is a good way to do that. Next slide, please. And then finally, we're looking to map some of those metrics around what we've just discussed: visits to the app library, downloads and recommendations by clinicians. So these are figures that we've been collecting for some time, and we're looking to change the trends of these over the course of our project. So hopefully we can see some exponential curves developing on these graphs here. So as well as getting feedback from our clinicians via survey data, talking to our specialist groups, we've got some quantitative metrics there too. And I think that's me. Thank you very much.
Thank you very much, Chris. That was really fascinating, and I can't wait to see how your project kind of develops. How far into it are you, out of interest? You said there's 9 months of secondment.
Yeah, so the So my secondment started in November, and we've had a second digital fellow join us more recently. Our engagement events started sort of mid-January time, so we're within sort of the first 6 weeks of engagement, and then we're due to run until August, all done.
Wow, brilliant. Well, really looking forward to see what the results are from your work. Thank you for taking us through it, Chris.
Thank you.
So we hit the time in the agenda where we'd love to hear from you and have a bit of a discussion. You'll see on the panel in front of you a small box which allows you to submit questions to any of our speakers or to them as a collective. So I'll invite you now, pop any questions into that chat. I'll see them ping up here and I'll put them forward to our esteemed guests on your behalf. But just to get this, oh, Helen, yeah?
Yeah, I've got a question for Chris. Am I allowed to do that?
Go for
Far
it.
away.
Okay, thank you. Yeah, no, really interested about the focus groups. Do those focus groups involve patients and getting feedback as to how they use the app and how they found it beneficial, or there were challenges, or just a general sense of whether it was an initial interest and then it faded? How are you getting that feedback from patients?
So, interestingly, those focus groups are focused around workforce at the moment and challenging breaking down those barriers for our workforce. Actually, gathering information from patients as to how they found apps is one of our biggest challenges as part of this project. ORCHA have helped with putting up a I forget what it's called, like a pop-up survey on the page when the patient goes on to download an app. So we're waiting at the moment, collecting and waiting to analyse that information. And the other thing we're looking to do is when we're giving out those QR code handouts for patients for recommended apps, we've got a QR code on there also with a feedback questionnaire. So I think it is one of the bigger challenges for us because we've got patients being recommended such a broad range of different health apps. And so collecting that all in one way is going to be is a bit of a problem, to be honest. So yeah, we are looking to do it through those two targeted ways so far, and then evaluate, and perhaps we will need to run some focus groups with patient groups as time goes on.
Thank you.
That's great. Thank you, Chris. I've got a question for the panel because I think we might get some different perspectives on this. Simon kind of told us that a lot of the return on investment benefits come from the scalability of digital health and from kind of scaling those incremental gains, which kind of leads on to the argument that you would think, therefore, that you get even greater benefit the more digital health solutions you deploy, whereas sometimes a lot of the quality improvement methodology is you do one small thing, you check, you make sure it works, and then you do another small thing. But at the same time, there are probably downsides to just trying to implement a larger range of digital health solutions at the same time in terms of, perhaps safety implications, perhaps overburdening your staff. I'm therefore keen to get the panel's perspective. When you're solving a messy problem like urgent care pressures, should we kind of fall back on the traditional approach of let's just do one small thing at a time, or should we try and implement several digital solutions in tandem?
I can kick off. Oh, sorry.
No,
yeah, just from our perspective at the Dorset ICB, we've been mainly looking to identify a top 5 set of apps within a particular clinical specialty and look to showcase those and promote those to our clinicians. Obviously, they will have pro licenses for the app library, so they'll have access to a bigger range than we showcase to them. But we've been going for roughly a top 5, and we are focusing mainly on apps that are in the free space at the moment, so that we're not asking our patients to shell out. As part of that, we're hoping by the end of the project to be able to identify what the gaps are in the offer for those clinical specialties, and therefore help to build a case towards what the more robust, perhaps commissioned solutions might be, which you then go on to really target use as an ICB.
I think I'll follow on from Chris in that it's always an interesting one when you choose to kind of pick a condition area, roll that out, and then incrementally move on to the next one. I guess from my perspective as a health economist, you kind of want to make sure that there's equal access for equal need. So it's almost by choosing one area, that area has a distinct greater importance than any other. It's perceived to be of either greater utility to treat that area or of greater benefit to do it right now. So for me, I think it's having the infrastructure to confidently be able to offer high quality digital health with minimal burden to healthcare providers to as many people as possible, because I think in that way we don't make any of those arbitrary distinctions between one area needing it more than another. So I think from my perspective, I'd love to see an array of options across an array of condition areas, but obviously with regard to array as well, you don't want too many for each condition area. That's the other thing. It's like the old fable of Buridan's donkey, where you've got the donkey in the desert who's dying of thirst, and then you've got two pails of water equidistant from it, one 10 meters that way and one 10 meters that way. Because it can't choose which one to drink, it ends up dying of thirst. So you want to be able to give something for each individual area, but not too much overlap therein, because otherwise people won't know where to look.
If I can, what was the name of that one? I'm going to quote that. What was that, Simon?
It's Buridan's donkey.
Buridan's donkey, thank you. I was going to comment about human factors, kind of ergonomics, kind of design thinking helps us reflect not about the work as imagined, but as the messy reality of work as done. And healthcare is incredibly complex, and so there are sadly no kind of magic wands or quick fixes for these challenging issues. So I think it's kind of making sure that if you're looking at a whole range of opportunities to streamline and make more efficient and effective and safe the care, it will be a range of activities you'll be doing. It's not like you can have a randomized control trial of this, but I think if you're designing ways of trying to provide better care in people's homes, primary care, and avoid those unnecessary and expensive admissions through A&E, then there'll be a range of interventions you want to do. I think the important thing is having some sort of evaluation framework as to whether it works or not. And I suppose part of what I was asking Chris about the patient perspective is that having the potential of digital health and the apps to make this significant change in people's monitoring and support in their own health interventions, it is great if it works. So it's kind of how do you move from the design to the delivery and the efficacy of that. So what kind of patient reported outcome measures do you have that supplement the kind of clinical perspective? And then there will be multiple interventions to deal, which is with a significant crisis in healthcare provision at the moment. But as long as we can try and identify what works and then get that feedback loop, that would be great. And I've got to ask of Chris, I mean, I think what you're doing in Dorset looks fantastic, and I love those kind of process maps of where you're trying to design apps into the clinical pathways rather than it being an add-on, it's kind of a supplement. I don't know if you've written that up at all, but we very welcome you sharing that and us putting it on the hub so other people can get the benefit of it as well. So maybe that's something we could think about separately with ORCHA about how we promote some of this good practice.
Thank you very much, everyone, for your contributions. So the answer seems to be, yes, you can do things in tandem, but don't overwhelm and make sure there's a framework for evaluating at the same time. We've got a few audience questions coming through. They're coming in fast now. So I'm going to direct this one to Chris and Helen. We've talked a lot about apps, but has anyone looked at the accessibility of the hardware? And by that, I'm presuming Fiona, who posed the question, is thinking in terms of kind of mobile devices and whether people actually have access to them. Are you aware of any initiatives to try and broaden access to health software that could help people?
So in Dorset, there are initiatives around providing hardware, but I think there are specific criteria for those things. In particular, the one I'm thinking of is around the homeless. So there is an initiative for providing devices for the homeless. Having said that, this is often a question that I get asked when I do these engagement events, is people worry about creating health inequalities by using these types of solutions. For me, we're really promoting these as synergistic or other options, choices within existing pathways rather than substituting existing care. So it's I can absolutely see where people are coming from, but we're not trying to remove the traditional care pathways. We're just trying to help those people that can self-manage make a choice to do so in a different way.
I'm not really sure I can supplement much more than what Chris has said, which I completely agree with. I'm not aware personally of kind of work in looking at hardware, but I would reinforce the importance of looking at these as an equity issue, and that what we're not unintentionally doing would be excluding certain population groups from having access to this or access to services if they're not able or willing to want to use digital health or apps, that there are other alternatives that are provided to them, so you're not reinforcing unfortunate equity issues. So I think the approach you're adopting, Chris, sounds a very, very positive one.
Thanks both. I've got one that's possibly best for Simon, as it really relates to, I guess, data, or if there's any research. Simon, are you aware of any data that demonstrates a difference in quality between paid or free apps? And do you know if there's anything out there that says, if they are paid apps, what payment models are considered most acceptable to patients, whether it's subscriptions or one-off payments?
So there are two answers to this. There is research out there around different payment models. There was a paper conducted by a Spanish group, which I reviewed, funnily enough. That's why I know about it. Otherwise, I wouldn't have known about it. Which looked at different payment models and preferences for payment. On your second question, yeah, I personally published some research in 2016 around looking at apps for insomnia only, and obviously there's thousands of other conditions. But we looked at the objective quality of the health apps at that time, and then correlated that with price of the health app and other things such as user downloads, user reviews, 1 to 5 stars. Found absolutely no discernible link between the two. It's worth stating that generally you would expect that apps that have a price behind them, if you look at market forces, have a price behind them, because generally an investor or somebody else has deemed them as the right idea, they've got the right traction, and they need to recoup all of that cost up front. So you would generally, like anything else, expect something with a higher price to generally be better than something with a lower price. But there's no absolute certainty on this. And I know at ORCHA we're working with the University of Ulster currently on looking at this precise question. We have a PhD student who's actively looking at this question. So in time we may have something more empirical with a larger number of observations, but I can share the link to the previous research quite happily.
Thank you, Simon. We've got another question actually around digital inclusion, really, and perhaps this one, maybe we'll go to Helen first and then to Chris. And that's whether, in your experience, Helen and Chris, are people consulting the public when they're introducing new digital solutions? And are people doing the equality impact assessments that they ought to be when introducing digital health? Do either of you have a view on that?
I'll come off mute. I'll have a start. I can't profess to be an expert, but I am, as the ex-chief exec of the Equality Human Rights Commission, I am very, very interested in this issue. So, are they being consulted? I think I presented at or chaired an event last year with the can't remember the name of the team in NHS Digital that do all the user engagement and user development, and certainly in terms of introducing digital health solutions, they're a very strong team that put equity and inclusion at the heart of what they do. So they have a capacity that engages with users and in the kind of design, development and implementation of digital technology. They were talking very much about how inclusion is a very strong part of that model. I know there's a significant change at NHS England, and NHS Digital are kind of becoming part of that team. I know there are big financial pressures, so I really do hope that team maintains the resources to support it, because they were doing some excellent work on that. But in terms of formal consultation, I'm not. I'm aware that the patient voices have been not patient voices, sorry, the Patients Association have been doing some active engagement and focus work, focus group work. Again, I think funded from NHS England, about digital engagement with patient communities. So there is work in this space. Apart from those two areas, I'm less familiar with it, but I don't know if it's any formal consultation. I'm not sure a formal consultation method, how that might work. I think some of the more direct engagement with focus groups and discussions might be the better way forward. But the programme with Patients Association is very active, and I'm sure you'll be able to see that if you access their website. I hope that helps.
That does.
From my perspective, yeah, just to give an example. So it's not my project directly, but the team that I work within, we're doing more of this around the commissioned app solution. So for the free space where we're recommending things go out to people, we don't get so much information about how they find them and the outcomes from it. But for commissioned solutions, so Tom earlier mentioned My Health, so that is one solution, one provider that's been commissioned in Dorset for COPD and asthma. So we do hold patient consultation groups around the design and rollout of these things, and we're fairly lucky in Dorset in that we've got the Dorset Integrated Intelligence Service, which is a data hub which has been created across the PCNs, the acute trusts, and community hospitals, where a lot of this data goes into a central repository, and so we are able to collect information around primary and secondary care attendances and why people attended, and for example around asthma and COPD CAT scores and adherence with medications. And so yes, we are able to see with those commissioned, and they're built deliberately around those commissioned solutions to be able to hopefully judge the value of that and support recommissioning if it's a good solution.
Thank you, Chris. And we probably have time for one more question, which I think to kind of help us wrap up, perhaps if we just go through each panelist, and I guess if you could share with the audience kind of one concrete step they could take if they're thinking about how can I use apps or digital health to start relieving the pressures in urgent care, what would your bit of advice be in terms of a next step from a, how do they make sure it's done safely? How do they make sure they're taking the workforce with them? And how do they make sure they're monitoring the impact effectively? I think that would be really a valuable way to close. Should we start with Simon?
Sure, yeah. I would treat digital health with the same respect that you would treat pharmaceuticals. And what I mean by that is that I wouldn't go in and assume that I can find something that's going to be safe and effective based on a cursory, quick review and treating health apps like they're washing machines or something else. I go to the experts who have created an entire industry and work continuously to make sure that these apps are safe and effective. And I wouldn't recommend a single technology to a single patient until I've been absolutely certain that it would first do no harm. So that'd be my takeaway message there.
Lovely, thanks, Simon. And Chris, do you want to go next?
I think this sort of speaks from my talk anyway, but I think we know the greater power of recommendations that come from a trusted clinician. And so engaging really well with your workforce and making sure that they feel comfortable and understand, like what Simon said, what they're prescribing and why, and that they can trust it.
Thank you, Chris. And then Helen to close.
I'm kind of linking those. So I think there's more work that needs to be done about a regulatory framework in this area. I think, if people are self-administering apps or having apps provided to them by trusted clinicians, but there's no evidence base of their efficacy or safety, that's a real concern. Not only because it might cause harm, but there's a missed opportunity for the improvement that you're looking for. But I think that's obviously the kind of negative side of it. But I think the flip of that is to be able to almost create a campaign of why this is a good idea, because these are new technologies, there are new ways of sharing knowledge and improving people's health. So it's getting information out in the public domain to the clinical community through initiatives that like Chris is doing, but also to the patient community about, you know, these are really, potentially these are really good things. And so I don't think there's much awareness within the broader community about this, and that would be something that I think the kind of almost part of a social movement for change and behavioural change. It's like, how do we get this out more widely known? So maybe some publications, campaigning, influencing strategy. We need to think about that a bit more.
Amazing. Thank you, Helen. And what a great note to finish on. I want to thank everyone that's joined the webinar today and all of our guests for coming and sharing their perspectives on this. I found it really fascinating. I know there's loads of questions we didn't manage to get to, loads of questions I've jotted down, but we'll be sharing a recording of this webinar. And if you'd like to get in touch with ORCHA, either to ask your questions or to explore how you can use digital health, then please just drop us a line at hello@orchahealth.com. Also, if you haven't already, please do read our report on how digital health can help reduce pressures in urgent care. It's a fascinating read. We've got some app recommendations in there to get you started, and hopefully it can be the start of your digital journey. But until next time, thank you very much for joining, and I hope you all have a wonderful day. Take care, everyone.
Thank you. Goodbye.
Bye.
Exactly.